लाइव हो गया? ओके लाइव हो गया, ठीक है, ओके। हाँ, ओके। सो yes, so I'll be taking to you through questions. Many of these questions which I have taken are from the PYQs. Okay, they are from the PYQs. That means the questions which have repeatedly come. ठीक है, सो कुछ क्वेश्चंस जो है वो PYQ है, कुछ क्वेश्चंस है which I have taken from the related to that theory which I find that the topic are really very very important. तो अभी आप देखो फर्स्ट क्वेश्चन, चाइल्ड, ओके, yes, so there's a child who is coming with a history of vomiting, right? A child coming with a history of vomiting, and the question is based on that what is this vomiting going to cause. So this is a question which is related to your acid base balance. I will also show you few of the questions which have repeatedly come on this topic. So this topic is really important. Now, before putting much looking into the options, metabolic acidosis or alkalosis, or whether it is respiratory acidosis or alkalosis. Now, when you are vomiting out, what do you vomit out is basically the acidic contents from stomach. That means there is a loss of acid. So a loss of acid means going to create what will be metabolic alkalosis, as simple as such. So when there is vomiting, there is loss of acid, so metabolic alkalosis. But when there is diarrhea, okay, when there is diarrhea, what happens when there is diarrhea? There is loss of bicarbonates. That means loss of alkali, which is going to result in metabolic acidosis, right? So whenever you are going into this question of acid base balance, which is not only important in your physiology but it is also important for medicine, दोनों में ये important है, ठीक है, physiology में as well as medicine में, where you are many of the times given how to diagnose it and all. So सबसे पहले you must know that you should always have a normal ABG, that is arterial blood gas analysis का values जो आपको learn होने चाहिए, ठीक है? तो आप देखोगे कि सबसे पहले आपको क्या देखना है, आपको उस क्वेश्चन को आंसर कैसे करना है. Look into the pH, what is given, whether it is an acidic pH or whether the pH given shows you more than 7.4, that is towards an alkaline pH. So the first step which will help me to reach towards my answer is going to be the pH. The second thing which I'm going to look upon will be my bicarbonates. ठीक है, will be my bicarbonates. So if the decrease in the H plus ions, that means an acidic pH is going along with decrease in bicarbonates. इसका मतलब जो pH का direction है and जो H plus ions का direction है less, it is going along with decrease in bicarbonate, दोनों का arrow mark एक ही direction में है, so it is metabolic acidosis. Similarly, if the H plus ion are reduced or if the pH is more, right? If the pH is more, यहाँ पर क्या था? There is a decrease in pH, right? And the H plus ions were less. अल्कलाइन पीएच है और बाइकार्बोनेट्स ज्यादा है, अल्कलाइन पीएच है और बाइकार्बोनेट ज्यादा है, सो इट इज गोइंग टू बी मेटाबॉलिक अल्कलोसिस. So metabolic is going to be associated with bicarbonates. Now sometimes what happens, you see that there is an acidic pH, okay, that means the pH given in a particular question is going to be less than 7.4, but here you find that the bicarbonates are raised. That means the pH and the bicarbonates, they are not going in the same direction. In that case, certainly it is going to be respiratory cause. Okay, the cause is going to be respiratory. Whether it is respiratory acidosis or whether it is respiratory alkalosis, whatever. But it is going to be the respiratory cause. So respiratory acidosis or respiratory alkalosis. So first is always look upon your pH, second upon your bicarbonates, and third what you go is then you look over to the carbon dioxide level and you come to that answer, because it could be then compensation which is shown to you, right? So if it is a metabolic acidosis, obviously the compensation is going to be respiratory as well as renal. However, if it is respiratory acidosis or respiratory alkalosis, the compensation will be provided mainly by the renal system. As far as the compensation is concerned, there is going to be increase bicarbonates with acidosis along with formation of new bicarbonates using important buffers, which are the phosphate buffers and the ammonia buffers. Remember, ammonia is a very important buffer, especially with chronic acidosis, right? It is a very important buffer with chronic acidosis, right? So these are the few causes of metabolic acidosis and alkalosis. And respiratory acidosis, that means increase in the partial pressure of carbon dioxide. Okay, increase in the partial pressure of carbon dioxide. That is any kind of condition where there is respiratory obstruction or there is a damage to respiratory center or there is ventilation perfusion mismatch, any case where the person is accumulating lots of CO2. ठीक है? Alkalosis, carbon dioxide washout. Very common is high altitude. So high altitude may, you get one question that with high altitude, what is the renal compensation? Remember, it is alkaline urine. This comes as a question to you when you speak of acclimatization. So acclimatization may alkaline urine. So this becomes an important question with high altitude physiology. Now, this was also a PYQ, and therefore I'm saying you that this question is really important. Acid-base balance. What is the normal anion gap? Right? So the normal anion gap is between 6 to 12. Now, what is this anion gap? So, yeah, similarly, in which condition in metabolic acidosis there is normal anion gap? We will look into this a bit late. Let me first explain you what is anion gap. So normally what we take into consideration is that the total cations is equal to total anions, but we are speaking about the measure, that is our sodium, potassium, okay, chloride, bicarbonates, which are usually measured. How about the unmeasured anions, right? So those unmeasured anions are going to be raised in certain conditions, right? So this normal anion gap is 8 to 16 milliequivalents per liter. It is 8 to 16 milliequivalents per liter. Now, this anion gap, remember, this anion gap is a very important diagnostic tool only in the case of metabolic acidosis. It is not useful for any other condition. कोई भी condition में anion gap का कोई काम नहीं है, right? So, there can be increase anion gap, metabolic acidosis, or they can be a normal anion gap, metabolic acidosis. Now, what is this anion gap? Anion gap is going to be increased whenever the amount of the unmeasured anions, your phosphate, lactate, they rise. तो जब भी unmeasured anions बढ़ते हैं in any particular acidosis, it is going to result in an increase in the anion gap. So just understand this. See, this is useful only in the case of metabolic acidosis. Metabolic acidosis is a condition where there is a decrease in the bicarbonate ions. Okay, now you remember bicarbonate means it is an anion. So whenever there is a decrease in the anion, that is bicarbonate, the body is going to compensate by increasing another anion. Okay, so if one anion is reduced, that is bicarbonate is reduced, the body is going to compensate by increasing other anion. This increased anion could be either chloride or it could be unmeasured anions. Unmeasured anions. So whenever the decrease in the bicarbonate is compensated by increasing the chloride. That means creating hyperchloramia, the anion gap is going to be normal, right? So anion gap normal with metabolic acidosis, that means a decrease in the bicarbonates was compensated by bringing about an increase in the chloride, and therefore the anion gap remained normal. On the contrary, if there is metabolic acidosis with a decrease in the bicarbonates and the chlorides are normal, that means the body compensated the decrease in the bicarbonates by increasing unmeasured anions. For example, diabetes, for example, lactic acidosis. तो यहाँ पर क्या हुआ? The anion which was increased is not chloride. So that results in increase in the anion gap. Okay, so increase in the anion gap will occur whenever there is going to be an increase in the number of the unmeasured anions, and remember that this is only applicable to metabolic acidosis. Right? So there are 2 to 3 questions which have repeatedly come on this particular topic. So therefore this topic is important. Yes, Sumit Kumar, Sandeep. Yes, Sumit. So if you guys are answering, then I'm going to be looking at the chat also now. The hormones and endogenous substances that are involved in the regulation of calcium. See, such a simple question, right? But these are the topics which are repeatedly touched. So what is the correct answer? A, B, C, D, which are involved in the regulation of calcium principally are, yes. The correct answer is definitely B, that is vitamin D, PTH and calcitonin, right? Now, what is important in this? Certain questions which are related to this topic. First thing we should understand some of the calcium binding proteins. Okay? Some of the calcium binding proteins. These are very good, Chitranjan, Simran and Madhu. Very good for giving me prompt answers. Good. So certain calcium binding proteins which are present in the body are chaliquestrin. Chaliquestrin is a calcium binding protein which is abundantly present in the skeletal muscles. Calmodulin. Calmodulin is the calcium binding protein in the smooth muscles. Troponin C. Very important calcium binding protein of the striated muscles. Calbindin. Calbindin, very important calcium binding protein in the intestine, and its level is increased by vitamin D. Its level is increased by vitamin D. Now, next important, certain factors which affect your calcium level. This is also important MCQ related to electrolytes. So, decrease in the calcium excretion, that means you are increasing the plasma level of calcium with PTH. First, parathormone. Second, with phosphate, vitamin D. Apart from this, whenever there is a decrease in the ECF volume, decrease in blood pressure, and also with metabolic alkalosis. Similarly, increase in the calcium excretion, that means you are decreasing the plasma level of calcium with decreased PTH, decrease in the plasma phosphate. Now, this is very importantly asked to us. Many of the times you see that acute respiratory alkalosis can result in symptoms of tetany. Right? Acute respiratory alkalosis can result in symptoms of tetany. What is the cause of that? So you remember that calcium, right? It is bounded. It is bounded. Now in acidemia, that means when there is an increase in the level of H plus ions, less calcium is bound to albumin or to the other proteins, especially albumin, because this time the albumin is occupied in buffering the excess of H plus ions, right? So in acidemia, what happens? That the free ionized calcium concentration increases because the proteins like albumins, they are busy in buffering H plus ions. But when there is alkalemia, that means when there is a decrease in the H plus ions, or when there is a deficiency of H plus ions, less hydrogen ions are available to bind with albumin. That means more sites are available to the albumin and it can bind to calcium. That means more binding sites for calcium. Therefore, what happens is that the amount of the free calcium decreases, and therefore with acute respiratory alkalosis there can be a tetanic like symptom, because with alkalemia, when the H plus ions are less, the proteins are free and they bind more of the ionized calcium, and that can result in symptoms of hypocalcemic tetany with alkalosis. This is also important question to you. Now, this is very, very important. That is the actions of PTH. Remember, when there is an increase in the plasma calcium level, okay, जब plasma calcium level बढ़ जाएगा, the hormone which can regulate it is calcitonin. The hormone which can regulate it is calcitonin, right? Because calcitonin immediately will cause a decrease in the bone resorption, and the calcium pools which were free will now be taken back into the bone. But whenever there is a decrease in the plasma calcium, the first hormone to be released will be your PTH. It is never going to be vitamin D. ये बहुत important है. Now, what does this PTH do? It has got a direct action on the bones. It has got a direct action on the bones, increases the bone resorption and therefore increase the plasma calcium level. It has got a direct action on kidney. On kidney, it is going to increase the renal distal tubular reabsorption of calcium. Increase in the renal distal tubules में. डिस्टल ट्यूब्यूल्स में ये कैल्शियम का अब्जॉर्प्शन बढ़ाता है, बट रिमेंबर इट कॉजेस फॉस्फेट यूरिया because it decreases the reabsorption of phosphate in PCT. It inhibits the sodium phosphate protein or the co-transporter, the sodium phosphate co-transporter which is present is inhibited, and therefore PTH is causing phosphate urea. Phosphatin भी बोलते हैं उसको. You also called it that phosphatin. The actions are mediated through cyclic AMP. So these two actions on the bone and kidney are direct actions. ठीक है? However, its action on the intestine is indirect. Indirect क्यों होता है? Now, in the kidney, it is what it is doing is that it is increasing the amount of, it is increasing your फॉस्फेट का रीअब्जॉर्प्शन को वो कम कर रहा है, कैल्शियम के रीअब्जॉर्प्शन को वो बढ़ा रहा है. But in the kidney, it is also resulting in increase in the formation of vitamin D, that is the active form of vitamin D. Where it is done in the PCT. This vitamin D which is increased will now act in the intestine to increase the calcium reabsorption by increasing its binding through calbindin. So action of the PTH on the intestine is via vitamin D. Therefore, remember boys and girls that it is also called as an indirect action of PTH on intestine. ठीक है? I hope I am very, very clear. समझ रहा है एकदम अच्छे से clearly. At least say yes, no, something like that. So I'll be free like yes, you know that. Now, an elderly patient comes with tremors, with rigidity and with bradykinesia. Now you know that these three symptoms, what do they tell us? They tell us that the person is suffering something which is related to basal ganglia, that is Parkinson's. And you know that which is the neurotransmitter affected? It is dopamine, right? It is dopamine. Very good, Mohammed. It is dopamine. With substantia nigra, degeneration of the dopaminergic. Yes, very good. So it is dopamine, which is which is over here now. Now see, if you look into the basal ganglia is actually very, very complex. You know, it is actually consisting of so many nuclei. Remember, all the nuclei of the basal ganglia are inhibitory except one. except one, which is subthalamic nucleus, which is the only excitatory nuclei of the basal ganglia, okay, with its neurotransmitter glutamate. Its neurotransmitter is glutamate. Rest all the neurotransmitters which are present here are inhibitory. And from the thalamus, these inputs which come to the basal ganglia are always excitatory, okay. Yeah, they are always excitatory, and they are going to come to the striatum. Striatum means there is caudate nucleus and putamen. Striatum means caudate nucleus and putamen. So all the inputs which are coming to the basal ganglia are coming to the caudate nucleus and putamen, which is called as striatum, coming from the cortex and thalamus, which is excitatory. The inputs, they leave from the basal ganglia via globus pallidus internal segment. Okay, globus pallidus internal segment. Then another thing which you must remember is that this dopaminergic neurons, they are present in the nigrostriatal system, that is in the basal ganglia, also present in the tegmental areas. This mesocortical system is associated with reward and addiction and certain psychiatric disorders like schizophrenia. On the extra edge, remember that the dopamine in the kidneys, it is a renal vasodilator. It increases the renal blood flow. Okay, increases the renal blood flow. Now, we know that Parkinson's is because of degeneration of the dopaminergic pathway in the substantia nigra. You must remember that lesions with the caudate nucleus results in chorea. Lesions of the subthalamic nuclei, hemibellismus. Lesions with the globus pallidus, athetosis. ठीक है, ये आता है. It also comes in the form of match the following. Now, a person with dementia diagnosed with Alzheimer's, which neurotransmitter is involved? The neurotransmitter which is involved in memory is acetylcholine. Okay, it is acetylcholine. Very, very important, neurotransmitter for working memory also. Yes, very good, Mohammed. For working memory also. Now, acetylcholine is a neurotransmitter at neuromuscular junction, in the autonomic ganglia, also in the postganglionic parasympathetic nerve target organ. It is also one of the very important neurotransmitter released everywhere in the CNS. It is involved in the sleep-wake cycle, in learning, in memory, and in Alzheimer's there is a loss of cholinergic neurons. So be very careful about, the neurotransmitters. Now, vitamin that increases the absorption of iron from stomach. The same type of question was also asked, wherein, options like tea, phytes, oxalates were given related to iron. Of course, we know that vitamin C increases the absorption of iron. Vitamin C. Tea, phytes, oxalates, they are known to decrease the absorption of iron. Right? So the chief site of iron absorption is duodenum. Now this is a very, very important, image where we must see that where we must see that how is the absorption taking place. So there is a ferric reductase. This ferric reductase, which converts the ferric form of iron into ferrous, which is the iron which is going to be absorbed. The transporter which is involved in the iron absorption is DMT, that is divalent metal transporter 1. It is a divalent metal transporter 1. Okay, this is a divalent, yes, very good, divalent metal transporter 1. Once the iron comes inside, from the basolateral side, it is going to be absorbed with the help of ferroportin and hephacetin. Ferroportin and hephacetin, right? The transport may, it is going to be along with transferrin, and the storage form is going to be ferritin. Okay? So divalent metal transporter 1 to be remembered on the apical side, ferroportin hephacetin on the basolateral side. Now, a patient was given halothane for general anesthesia and he developed rigidity and hyperthermia. These symptoms are because of which ion? Okay, these symptoms are because of which ion? Yes. So this is a question which is related to a channelopathy. These are the questions which are related to channelopathy. These channelopathies can be either affecting your excitable tissues or your non-excitable tissues. Excitable tissues means here it is malignant hyperthermia. This condition is malignant hyperthermia, right? Excitable tissue, even certain myotonias affecting channels affecting the cardiac muscle or affecting the skeletal muscle at the neuromuscular junction, those becomes mutation of the channels of the excitable tissue. But mutations, for example, cystic fibrosis affecting the CFTR channel, the cystic fibrosis transmembrane receptor channel, which is involved in the respiratory system, in the pancreatic system. And the mutation of this chloride channel results in cystic fibrosis and also Barter's syndrome. Barter's syndrome, which is again a channelopathy affecting the potassium, the chloride, the Bartine channels which are present in the thick ascending limb of the loop of Henle, right? Now, this malignant hyperthermia is because of the mutation of the channels which are present in the in this rhinodine receptors. These are the rhinodine calcium channels. Okay, rhinodine calcium channels. So see, this is the sarcotubular system. These are the T-tubules. The T-tubules have got the dihydropyridine receptors, that is the voltage sensors. And these are the calcium channels, which are the rhinodine channels, which are present in the L-tubules. So, wherever there is a mutation of these calcium channels, there is an excessive release of calcium and the person develops increase in the muscle contraction, because of which there is increase in the heat production in the muscle. It is called as malignant hyperthermia. And the persons who are susceptible can develop the symptoms more severely with certain anesthetics like halothane. Now, a 5-year-old boy is brought by mother because he has got a difficulty in walking. At the age of 11 months, when he started to walk, right, mother realized that there is a difficulty in raising from the floor. He's not able to get up properly. The calf muscles are hypertrophied on inspection, and he is walking as if he is climbing. That means he has to support his thighs. He'll keep his hands on his thighs, which is a typical sign which we called as the Gower's sign. Yes, very good, Mohammed. Anish, good. So it is because of mutation of a very, very important protein, that is dystrophin. dystrophin. It is the Duchenne's muscular dystrophy, which is X-linked recessive. X-linked recessive due to total absence of dystrophin. There is a mild form where there is a reduced in the content of dystrophin, which is called as the Becker's dystrophy. Yes. Now next one. The first heart sound coincides with which part? Yes, Mohammed. Titin is the largest protein. See, if you look into the proteins of the skeletal muscle, there are contractile proteins which are actin and myosin. There are regulatory proteins which are also called as the relaxing proteins, which are troponin and tropomyosin, and there are certain anchoring proteins, right, which is titin and nebulin, actinin, right, SA. Okay. Yes, so Muhammad and Saddam, you've given the correct answer. The first heart sound coincides with which part of the cardiac cycle? It is isovolumetric contraction. So what is isovolumetric contraction? It begins as soon as the AV valves close and the ventricles are converted into closed chambers. Okay? The ventricles are converted into closed chambers because of the closure of the AV valve, producing the first heart sound. Now, this is very, very important, which we will take in the form of this Weger's diagram. Weger's diagram reflects on a same graph heart sounds, that is phonocardiogram, ECG, recording of the electrical events, pressure, volume changes. All of them, they are reflected on the same side. Now, whenever you are studying this diagram, always start with the ECG, that is the electrical events. For example, when we start, this is the QRS complex, okay, QRS complex. The QRS complex means the ventricles will depolarize. As the ventricles depolarize, that means this is the electrical event, it will coincide with the mechanical event, that is isovolumetric contraction. So the QRS complex on the ECG is going to coincide, or it will be just before the closure of the AV valve. The closure of the AV valve means beginning of the isovolumetric contraction, production of the first heart sound, and beginning or the onset of systole. The pressure rises, and at a point the ventricular pressure will become more than the aortic pressure, resulting in the opening of the aortic valves and ejection. As the pressure is more during the ejection, you will see that the volume starts to fall. So the pressure rises and the volume falls, right? So this ejection phase will continue till the pressure in the ventricles fall. There is closure of the aortic valve. So you can see that the closure of the aortic valve, it is just preceded by T wave on ECG, that is reflecting ventricular repolarization. So here you get the second heart sound, okay, with the closure of the AV valve, a second heart sound, and on the aortic pressure curves, you get insusura, a dicrotic notch. Insusura, a dicrotic notch, which then is followed by diastole, that is relaxation. So as the first heart sound tells you it is a beginning of systole, the second heart sound tells you that it is beginning of diastole. The pressure in the ventricles drop till the AV valve opens, and again you see that as the pressure drops, the volume curve will start rising, right? So we started with end diastolic volume of 130 ml and we completed with contraction followed by ejection with end systolic volume remaining 50 ml. The same type of the question is asked in the form of a graph and also in the form of this volume pressure curve, where on the x-axis there is left ventricular volume, on the y-axis there is intraventricular pressure. The segment A to B reflects reflects the filling of the ventricles, right? From A to B there is filling of the ventricles. So point A, where there is 50 ml, reflects the amount of volume remaining in the ventricle at the end of systole, which was 50 ml. Then there is period of filling. So point B is the point where there is going to be the closure of the AV valve, and this is the point where there is going to be S1. This comes as a image based MCQ. Okay? Image based MCQ. So this is going to be phase 2, which is isovolumetric contraction, which comes to an end with the opening of the aortic valve, that is the semilunar valve. This is going to be the phase 3, which is the period of ejection, which comes to an end with the closure of the aortic valve. So S2 is just diagonal to S1. This is the fourth isovolumetric relaxation. This extreme left is the end systolic volume and this is the end diastolic volume. And from this given graph, you can calculate stroke volume, which is end diastolic volume minus end systolic volume, right? You can also calculate the ejection fraction, which is stroke volume divided by end diastolic volume into 100, right? So this is a very, very important graph related question. Now, see, similar PYQ. These are all PYQs. That means these are really highlighting or important topics. Which of the following is true for IVC, that is isovolumetric contraction? AV valve close, semilunar valve open, C wave of JVP and corresponds to QT interval. So the best option is closure of the AV valve. Yes, closure of the AV valve, right? Now C wave of JVP, okay, this is going to be seen only in right atria. This is right atrial pressure changes. Therefore, the best answer would be the closure of the AV valve, because the cause of the C wave of JVP, if you see, is the tricuspid valve. It bulges into the right atrium, है ना? तो ये confusion हो सकती है, लेकिन best answer रहेगा closure of the AV valve. Now, there are many questions which come on the clotting pathways. So which of the following is an extrinsic clotting factor? You know that there are two clotting pathways, intrinsic and extrinsic. When you are remembering this, no, it's not ventricular filling, Mohammed. It is bulging of tricuspid valve into, it is bulging of tricuspid valve into right atrium. Okay, it is not because of that. Yes, very good. Extrinsic factor is factor 7. Now, जब भी आप ये वाला पैथो में भी ये करोगे और फिजियोलॉजी में हिमैट में भी आप ये करोगे, आपको सबसे पहले याद रखना है कि there is a common pathway where the prothrombin is converted to thrombin, right? This is the common pathway which is taking place, and there are certain factors which are very, very peculiar or only for extrinsic pathway. Like see, tissue factor, factor 7 is very important. अगर आप intrinsic देखोगे तो intrinsic pathway में you will get different factors. So there will be factors which are specific for intrinsic, specific for extrinsic. The next thing which you should learn with this is what are the specific tests for extrinsic and for intrinsic. And there are certain factors which are going to be common to both intrinsic and extrinsic. So remember like that. Now, the next very important highlighting question is on clearance. बहुत बार आता है clearance for FMG and also for NEET-PG. Which is true regarding creatinine clearance? It is less than inulin, more than inulin, equal to inulin, or none of these. Now, we know that inulin, when we look into for clearance and we want to find out GFR, the gold standard is inulin. And with inulin, it is 125 ml per minute, which is same as that is your GFR. But for practical purpose, instead of inulin, we prefer creatinine because it is a product of muscle metabolism and we need not give it exogenously. However, since a small amount of creatinine is secreted, okay, a small amount of creatinine is secreted, the clearance of creatinine is always going to be more than that of inulin. Okay, the clearance of creatinine is going to be more than that of inulin, which is 140 ml per minute. Now, this is a very, very important formula. Clearance is urinary concentration of a substance divided by plasma concentration of a substance into V, that is a urine volume rate, urine flow rate. Remember that the clearance का जो आंसर होता है, it always comes in ml per minute. जो वैल्यू यूनिट है x की, मतलब यूरिनरी कॉन्सेंट्रेशन या प्लाज्मा कॉन्सेंट्रेशन, ये हमेशा होती है मिलीग्राम पर ml. It could be even gram per liter. It could be even, milli equivalents. It is never per minute. It is never per minute. However, the urine flow rate is in ml per minute, and therefore this ml cuts, and therefore this milligram per ml cut, and therefore clearance का जो value आता है ये हमेशा आता है आपका ml per minute में. This is a very, very important topic and a repeatedly coming topic. So इसको अच्छे से करो आप, clearance को calculate करने के लिए भी आता है ये. यहाँ पर जो question आता है वो होता है clearance graph पर. Clearance graph पे, जैसे इसमें तो it is already marked. You may be asked what is this, this and this. If it is not given, what are these and why are these? Yes. Now see, this straight horizontal line is inulin clearance, because inulin is a substance which is only filtered. It is neither reabsorbed nor secreted. Neither reabsorbed nor it is secreted. Glucose is a substance which is reabsorbed. So normally the glucose clearance is 0, because there is no amount of plasma which is anytime cleared of glucose. So the clearance will be always 0. However, in conditions like diabetes mellitus or conditions glycosuria, when the amount of glucose coming in the urine increases, okay, when the amount of glucose coming in the urine increases, because now there is decreased reabsorption of glucose due to saturation of the proteins. तो ऐसे conditions में क्या होगा? The clearance of glucose will rise. So you can see that this is the rising of the clearance of glucose, which tells you that there is failure of reabsorption of glucose. But in certain substances like PAH, which is para-aminohippuric acid, which is a substance which is secreted, and it also shows saturation kinetics because it is, secreted with the help of a carrier protein. So अगर ये substance अगर ज़्यादा हो गया है, so what will happen? There will be saturation of the proteins or the transport proteins which are secreting it, and therefore the clearance of a substance which is secreted goes on decreasing. Right? The clearance of a substance which is secreted will go on decreasing, but the clearance of the substance which is reabsorbed will keep on increasing. This is the reason of saturation of the carrier proteins. right? Saturation of the carrier proteins. Now, which of the following is true? Okay, which of the following is true regarding GFR? Increase in the renal blood flow increases GFR. Increase in the sympathetic function increases GFR. Afferent arteriolar constriction increases GFR. Decrease in the renal blood flow decreases GFR. So the best answer is, with increase in the renal blood flow, there is increase in the GFR. The renal blood flow and the GFR, both of them, they show auto regulation in the range of 80 to 180 mmHg, sorry, in the ratio of in the range of 80 to 180 mmHg. 80 to 180 mmHg. Both of them show auto-regulation. There are two mechanisms by which they show auto-regulation. First is the tubuloglomerular feedback mechanism. Tubuloglomerular feedback mechanism, which is working at the level of the distal tubule. And you know, the most important cells are the macula densa cells. The macula densa cells are called as the sensors of the tubuloglomerular feedback mechanism. The second is called as the myogenic mechanism. The myogenic mechanism, which is based upon calcium. Okay, calcium. Because whenever there is an increase in the blood pressure, there is going to be the stretch of the smooth muscles and opening of the stretch sensitive calcium channels. This calcium, it comes inside, causes contraction of the smooth muscles of the blood vessels, and it resists the blood pressure. That means the blood flow will never increase even if there is an increase in the blood pressure. Now, as far as the factors affecting GFR, you know that there are Starling forces which are regulating your GFR. Hydrostatic pressure of the glomerulus is the only driving force which increases filtration. Okay, which increases filtration. Hydrostatic pressure of the glomeruli, only force which increases filtration, or it is the force which favors filtration. Okay? And the colloidal osmotic pressure, the colloidal osmotic pressure of the glomerulus, pi GC, it is going to decrease your filtration. And the hydrostatic pressure of the Bowman's capsule is also going to oppose filtration. So you have got two opposing forces, the colloidal osmotic pressure of the glomerular capillaries and the hydrostatic pressure of the Bowman's capsule. And you have only one favoring force, that is hydrostatic pressure of the glomerulus. So any factor which will increase the hydrostatic pressure of the glomerulus, for example, increase in the mean arterial blood pressure, or afferent arteriolar dilatation, or mild to moderate efferent arteriolar constriction. Mind well, I said constriction. Mild to moderate efferent arteriolar constriction and afferent arteriolar dilatation. These are the factors which increases the hydrostatic pressure and increase the GFR. Yes. Now, a large V wave on JVP. Remember, JVP is very, very important in medicine as well as in physiology. Yes, it is with tricuspid regurgitation. See, jugular venous pressure, right? Now, the right jugular vein has got a direct communication with the right atrium, and therefore, when you measure the pressure, it gives you an idea of the pressure of the right atrium, right? So, for the right atrium, you use the jugular venous pressure, but for the left atrium, you use the pulmonary capillary wedge pressure. Pulmonary capillary wedge pressure. This jugular venous pressure has got three positive waves, A, C, V, which are reflecting a rise in pressure in the right atrium, and two negative waves, X and Y, which shows a decrease of pressure in the right atrium. A wave is because of the atrial systole. C wave is because of the bulging of the tricuspid valve into right atrium, which occurs in isovolumetric contraction. V wave is because of the filling of the atria. When they are in diastole, when there is filling of atria, the pressure will rise. X wave, atrial relaxation. And it is actually, atrial relaxation when the ventricles are ejecting their blood. When the ventricles are ejecting their blood, meanwhile the atria are relaxing, at that time you get the X wave. And Y wave is when the blood passes from the atria to the ventricles. That is when there is when the last part, when there is last part of the ventricular filling, and when the blood passes from the atria to the ventricle. So as the blood passes, as there is emptying of that atria, the blood volume decreases, and so the pressure also falls. Now, which of the hormone has got a positive effect on LH surge? It is an example of a positive feedback mechanism, and it is because of estrogens. Due to an unknown reason, estrogens normally do not have any stimulatory effect on LH, but it is only during ovulation that they have got a positive feedback effect on LH. Remember that this is very, very important graph related question with the female reproductive system, where you must know that there is a a pre-ovulatory period, which is also called as the proliferative phase, which is because of the estrogens. During ovulation, there is LH surge. In the post-ovulatory period, there is a rise of progesterone. Okay, a rise of progesterone, which is the secretory phase. Very interestingly, you will see that when there is actual blood flow in the menstrual phase, that is from 0 to 4 to 5 days, when there is bleeding or when there is shedding of the endometrium, the level of FSH is high, right? The level of FSH is high. And after that, you will see that the level of estrogen also rises. But here, when there is actual bleeding or the shedding of the endometrium, there is a withdrawal of the hormone estrogens and progesterones, that what results in bleeding of menstruation. And because the estrogen level goes down, there is no feedback to regulate FSH. The FSH level is going to be more. So, follicular phase estrogen, they have got a negative feedback effect on anterior pituitary. Mid-cycle, again estrogen having a positive feedback effect for LH. Luteal phase, both estrogen, progesterone, however the progesterones will be more, having a negative feedback effect over the anterior pituitary. Now, a patient having unilateral drooping of eyelid, muscle weakness, headache, these symptoms worsen during evening, and patient feels better after taking neostigmin, or even the patient feels better after taking rest. If this, instead of tablet, neostigmin, if it is very clearly given to you that the patient feels better after rest, mind well, it is going to be myasthenia gravis. Okay? Yes. Now, यहाँ पर what I would like to tell you is, what is Lambert-Eaton syndrome? This syndrome is associated with calcium channels which are present on the presynaptic side. That means, see, if you look into the neuromuscular junction, this is the motor neuron. Okay, and this is the muscle. Muscle is thrown into folds called palisades, and here are your acetylcholine receptors. ठीक है? And towards the motor neuron where there are vesicles which will be released, which contains acetylcholine. यहाँ पर there are voltage gated calcium channels. So when there are antibodies presynaptically, that is against the voltage gated calcium channels, there is Lambert-Eaton syndrome, and when there are antibodies against the nicotinic cholinergic channels on the postsynaptic side, it is myasthenia. The difference is that when the person works more or towards the evening, there is a fatigue. These symptoms are more towards myasthenia. But if the person works more, he feels better after exercise, the symptoms are of Lambert-Eaton. ठीक है, मतलब एक्सरसाइज करने के बाद उसको अच्छा फील हो रहा है, दैट इज Lambert-Eaton. शाम होते होते, exercise करते करते, yeah, no, sometimes it is given that even while chewing food he gets very tired, again myasthenia. So be very, very careful with this. Also, at the level of neuromuscular junction, remember one more important thing, that a person comes with a history of diarrhea and then develops flaccid paralysis. Okay, history of diarrhea and then comes with flaccid paralysis. This is a condition with a toxin of botulinum. The botulinum toxin, which acts in a way that to interrupt the function of the docking proteins. Okay, it interrupts the function of the docking proteins and prevents the release of acetylcholine. Okay, it prevents the release of acetylcholine, which causes failure of the action potentials to develop, and the no Mohammed, it is not GBS beta, it is botulinum toxin के वजह से it is a flaccid paralysis, and the patient comes with a history of raw meat, uncooked meat. ठीक है, वैसा इसका हिस्ट्री है. समझा आपको? Got it? Okay, so I hope the session was interesting to you. If you want that I should take another session, I can plan it day after tomorrow. One more hour I can take. If you want, I can take another hour, like day after tomorrow I can plan. If you guys are interested in more PYQs, so I can take. So let me know that if you want more PYQs within this week, Saturday or Sunday, I can plan another 1 hour session for you guys, अगर आपको चाहिए तो. I hope you learned today. कुछ सीखा आपने, कुछ समझा? Yes? So अभी particularly I would say you do lots of revision, like do lots of revision. That would be very, very helpful to you. And let us plan one more session. I'll ask to the team to plan one more session to you, right? So good night. Yes, interested. Okay, फिर हम लोग एक और सेशन रख लेंगे, ठीक है? So for now, good night everyone. Take care and best wishes.